Hello, my name is Philip. In this presentation, I will discuss PD catheters care plan. Peritoneal dialysis is a widespread treatment for kidney failure. As a patient, you should learn about how to make PD more effective and minimize side effects. Learning about your treatment, you can work with your healthcare team to give yourself the best possible results, and you can lead a full active life. The learning outcomes are review the different types of peritoneal dialysis catheter and use an example to help a patient how to choose the best suitable catheter and provide the informations of the pre-insertion preparation of the patient, pre- and post-operative care, and educate patient for the care of the PD catheter and exit site. The standard catheter for PD is made of silicone, which is a soft tubing for comfort. It has cuffs made of a polyester material called Dacron that merge with your scar tissue to keep it in place. The end of the tubing that is inside your abdomen has many holes to allow the free flow of solution in and out. There are three types of catheter. They are Tankoff catheter, Swan neck catheter, and the Toronto Western catheter. Each of them has a straight and coiled variation. Here, I use the coiled Swan neck Missouri catheter as an example to discuss how to choose the catheter for pre-sternal peritoneal dialysis. The Swan neck Missouri catheter for pre-sternal is made of silicone. It is a modification of a lower abdominal catheter that allows for an anterior chest exit site. It has two sections are joined together internally with a titanium connector. The upper section has a performed band which is a swan neck, two cuffs, and an external segment. The lower section has a Missouri intraperitoneal design. The reason of choosing this catheter is less movement with the chest wall than abdominal location. This improves healing and decreases trauma risk. And the pre-sternal catheter is good for patients with ostomies, incontinent, obese abdomens, or those once tub base. The advantages of the pre-sternal catheter are less movement than abdominal wall and fewer infection and no pressure or irritation from belt or clothing and better healing of exit site. The disadvantages are more complicated to insert the catheter and more expensive, and should not be placed over the sternum in the event of patient has to have open heart surgery. Before the insertion, we need to do pre-insertion assessment to find any problem. For example, if hernias present, consider to repair it during insertion or before the insertion. Assess the exit site with the patient dressed and sitting to avoid any skin folds and creases. Determine the PD exit site together with patient to promote participation in care and self-management. Before insertion, patients also need to do some psychological preparation, including patient and family has the skill to undertake the dialysis themselves, and social support in cooperation with personal and professional activities and nutrition and medication regime and any potential change to body image and physical pursuits. The preoperative care of the patient included but not limited, such as patient need to take a chlorhexidine shower on the morning of the insertion, empty bowel, empty bladder, and clipped hair from the surgical site, and do bacteria screening and take antibiotics for the high risk of infection. The post-operative care of the patient included but not limited, such as exit site dressing should remain undisturbed for around 10 days after the insertion, and minimize any bacterial colonization of the exit and tunnel during the early healing period, prevent any trauma to exit site and traction on the cuffs by immobilization of the catheter. Flush the catheter with 1 liter of PD fluid solution to check for patency. Don't start PD treatment until healing at exit site and tissue ingrowth into the catheter's darkroom cuff have taken place, usually need 10 days. If dialysis is required during this healing period, use automated peritoneal dialysis to lower with low volumes supine position to minimize intra-abdominal pressure to prevent leakage. The long-term care of the exit site, including but not limited as thorough hand washing before touching catheter or exit site. Clean the exit site with liquid antibacterial soap. Use clean washcloths and towel for the healed exit site. Institute a regimen for prophylaxis of Staphylococcus aureus. You should always secure the catheter to promote immobilization, reduce risk of trauma and infection. Avoid submersion of the exit site into lakes, rivers, streams, bathtubs, and hot tubs due to high bacterial counts. Thank you for watching. Have a good day.